I'm going to do my best to set this up. And this is something that I've been really looking forward to because it's really pulling together several threads that the Coordinating Center team has been working on, honestly, for a couple years now. So we're going to do a deep dive into exploring within our quality measurement, quality initiative portfolio, differences in care related to social demographics and important age groups within the ED population. Um, and this is going to include doing some deep dive into new reporting capabilities that we're going to be showcasing today, and some small group activities to allow you all to explore within your own site potential important sort of key differences in quality performance across different populations within your ED. So we've called a consult and have some external speakers from a group called M-Shield, which is a similar CQI to ours, MEDIC, that supports work in social determinants of health and disparities in care. So they're going to ground us in sort of how we go about interpreting data, because I think it's really important that we understand kind of the foundations before we begin to explore some of these differences. So we've got two speakers here, Matthias and Selena, and I'm going to ask you guys to come up, and then after that we'll hear from Chris Flung. So floor is yours.
Yeah.
All right, good morning. So we are here today to present about this topic of disaggregating data for quality improvement. So oftentimes with quality improvement, we're thinking about reaching a goal for a particular outcome. And what we're really wanting to focus in on today is a little bit more about, well, what if some groups aren't meeting it at a much higher level? Or what if some groups are getting there and some aren't? What's the difference between them? So kind of really thinking about that dynamic within our data. So first we can talk a little bit about why M-Shield is here today. So as Keith said, we are also a CQI. We're dedicated to looking at quality improvement from the aims of what kind of social needs do people have? What are non-medical drivers of health that people might encounter? So we know that CQIs and MEDIC included have really been leading the nation in achieving the triple aim of improving patient care, lowering costs, and improving health. However, we could say that we have already gotten a lot of the really easy wins, I suppose you could say. So, reducing use of less effective or costly surgical care, let's see, reducing post-acute length of stay, things like this. But for the next level of QI, we really want to think about some next level approaches. So we've worked really closely with Blue Cross Blue Shield of Michigan and the different CQIs across the state to identify some novel areas of quality improvement for patients throughout Michigan. And one way we can do this is using data dashboards that disaggregate on patient demographics. So there's many reasons organizations may want to use disaggregated data, including understanding experiences of different communities or looking for trying to achieve a goal of health equity. So today we're going to specifically talk about how it can be used to leverage overall quality improvements. So first, let's start by examining some of those other motivations. One of the measures that MEDIC has been working to incorporate into dashboards is race and ethnicity. So we know that race and ethnicity categories are often used as proxies for what might be true concepts or variables of interest. So in addition to self-identified race and ethnicity in the categories that we've kind of come to know, we can think about other concepts that are related to this, such as the relational aspects of race, how people relate to others in their communities based on how they identify, the environment that people live in, access to work, food, and transportation, ethnic and cultural practices, languages, religions, immigration status, and degree of acculturation, indigeneity, skin color and pigmentation, which can impact different types of testing that we might be doing, ancestry, genetic markers, genetic variation, social and stress-related biomarkers, and other biological indicators. But it by no means is race and ethnicity like going to tell you all of this stuff just by one thing, but it can kind of point you in the direction of there might be some of these other things underlying differences between groups. We know that in Michigan, our population is made up of mostly non-Hispanic white individuals. And just because of the sheer numbers of individuals in that population, it tends to drive the overall population trends. So when we look at overall numbers only, we might be missing key differences in how policies or practices are impacting different communities. This can lead to unmet needs for certain populations, making them invisible in our data sets. And that might help us if we understand a little bit more about what different populations are experiencing. We could understand what types of resources need to be allocated or what kind of programs might be implemented. But as we have no, race and ethnicity is just one patient characteristic that we might want to look at. And I'm sure you can think of many other indicators here. And depending on where you are in the state, those will be different, right? So age might be a really important one if you're in a place that doesn't have a children's hospital, like thinking about the age of younger patients coming in versus older. You might also think about where people live. Are they rural? Are they traveling many miles to get to where you are versus people who live close? So all of these things are really important features in how people might be interacting with the healthcare system and how they might interact with your emergency department in specific. So we want to kind of walk you through a data example here about why data aggregation choices might matter. So much of the time, quality improvement goals, they're set on this aggregate level, like I said. And it makes sense because you've set a target here that represents a high quality of care that you want to get all your patients at. So consider this case. You set a target where you want 80% of your patients in the emergency department to be triaged within a certain number of minutes. So you can look at the trend here overall, and you can see that you're getting really close to the target. So you've moved from about like 70% and you're almost at 80%. This is the aggregate. So however, if you disaggregate this into two different groups, and group B here is the smaller group, you can see that there's a kind of a different story happening. In fact, the group that makes up the majority of cases already has hit that 80% mark. They've gone over the line. So for some group of patients, this is working. Whatever you're doing to improve the triage is working. But there's this other group that in the last few months has actually been going down a little bit. And you might wonder, well, what's going on with them? So it could represent many different factors. Maybe it's people who this breakdown between group A and B. This could be any number of things, like could be rurality, it could be race and ethnicity, it could be the time of day people are arriving at the emergency department. Whichever it is, though, it represents an opportunity for your organization to address the barrier to receiving care. So I'm going to turn it over to Selena now. She's going to talk a little bit about how to disaggregate for quality improvement and what that would look like.
Thanks, Matthias. Okay, so Matthias very nicely walked us through the importance of disaggregating data in terms of making sure that we're not missing any sort of subgroups, right, that may need more resources. And so I'm going to walk through sort of surface level what we can do to disaggregate for quality improvement. And so data disaggregation can be used to identify groups of patients who may need additional resources to reach healthcare goals. And in the case of quality improvement, we can look at group-specific outcomes for quality benchmarks. And that is something that we want to point out in terms of when we're setting these goals, in terms of our outcomes, we want to be looking at a benchmark that we can look at across all groups, right? Not comparing the groups against each other per se, but setting that benchmark, and that's where we want all of the groups to be reaching to. And so in doing this, this may show how some groups who are doing well and how others, with the current methods that we're using right within our quality improvement methods, that are not sufficient. And then targeting the groups who are not reaching this benchmark can help them to get closer to the goals that will help them to get to that benchmark goal that we're setting. And that is sort of like the overall goal of like what we're doing, right? And the sort of being able to disaggregate data is one of the tools in terms of being able to identify the different groups that we may have been missing when we have aggregated the data. And so going back to that example that Matthias like very nicely walked us through, if your organization could develop a targeted plan to improve the outcomes for group B, then the results help not only that group, but also your overall QI goals. And the targeted effort not only greatly improves the triage rate for that group, but then it lets your organization meet that end of the year goal of the target that you have set out at the beginning of the year. And so there's just two arms, right, in terms of like the benefits of one, disaggregating the data, and then improving our QI methods in terms of helping each of these groups. Is one, it helps the patients themselves, right? And that's always our number one priority. And then two, within our own quality improvement goals, it helps us to reach those targets that we've set out within our own sort of organizations. And so overall, it is, you know, everyone's improving, and that's like what we're that's the main goal. And so we also want to sort of outline some common pitfalls and best practices when using data. First, when looking at different groups, instead of comparing racial or ethnic groups to each other, I mentioned before that we want to set a benchmark and then use that benchmark to make sure that each of the racial or ethnic groups are, that's like the goal, right? We're not looking within group differences or anything like that. It's always just the benchmark goal. And if that's like the one thing that you take away from this, like that's like the main sort of thing that we want to get across. Further, sometimes within our different demographic groups, depending on where we are within the state, there may be small groups, right? And it could be tempting to then sort of lump these smaller and population groups like into another group that's just called like other. But we want to avoid doing that because it doesn't really help to address any of the disparities that we may be seeing. And then also from, you know, thinking about from a patient perspective, like if you are looking at a figure and you're trying to look at like which group you may belong to, like looking at it and just seeing that you've been grouped into the other is very sort of like isolating, and it's also, it is in a sense like othering, and we don't want to like sort of, that's not the perspective that we want to be taking with our patients. And so as much as possible, we want to look at the different distinct groups and be sure that we can address any of the challenges that come from the low numbers. And, you know, one specific example of this is people who may have multiple racial identities. And what you could do in there is looking, if we have the data for each of the specific identities, is grouping them not in this like multi-racial or multi-ethnic identity, but looking at each of those different combinations and perhaps creating a group that way and seeing how that pans to the benchmark. And then in terms of other demographic variables, when comparing different groups within the age composition, we also want to account for differential outcomes. And so whenever possible, we should adjust for age or look at age-based subgroups. And then also when looking at gender and sex, we can also create, that can also create complications, right? Depending on how we are grouping. And so one of the things that we want to sort of stress is to be consistent in the approach that we're using with these measures and specify how the measures are being used, and then to address the limitations of the data there. So to sort of give you an example of how to incorporate these practices in like a data visualization, I want you to consider this chart. This is demonstrating the best practices, this is demonstrating performance by race or ethnicity through a patient attributes title. And so here we see that this title, it corresponds to, okay, if we're looking at performance, and this is like how we have presented the different subgroups, and it's also telling us where the data is coming from. And so in this, it's very clear, and it answers sort of those questions of what is the data, how is it being looked at, and where is it coming from. In this too, this figure, we have footnotes for the data in terms of which sample populations were too small to report, how much of the data was not reported due to missing data, and then also the years in which the data was collected. We also have within each of the different subgroups, we have the specific sample size for each. And we've also alphabetized the presentation of the race ethnicity groups. But I do want to stress that the alphabetization does not indicate any sort of hierarchy. It's just to alphabetize it. That's the main purpose of it. We also have these two groups here where prefer to not answer and unknown. And those are for, potentially patients who have written in, within the race ethnicity question, if they've written in an answer and we're not able to group them into any of these other subgroups. And so, yep, this is just like one example of how to incorporate those sort of best practices and visualization that maybe you can incorporate in the dashboards that you'll be using. And then another sort of best practices in terms of thinking about the data and what the data represents. One sort of method to make sure that we're being equitable in that is to incorporate the role of patient voices and to sort of like think about what the data is in general, right? Like, yes, we have these numbers, we have the qualitative data if it's not numbers itself, but the data represents like the patients, right? And if we're able to incorporate the role of the patient, then we're ensuring that it is representing sort of like how they want to be presented in the measures that we are gathering. And so this is important because it improves relevance and the impact of our quality initiatives, right? Patients are able to provide insights into what actually matters to them. And then this helps to make QI efforts more targeted and meaningful. It also, incorporating patient voices also helps to reveal hidden gaps, especially if there's something that we're not able to capture like in the numbers, right? If we have some sort of like narrative like from the patient, then we're able to understand more their lived experiences, and maybe that is providing that sort of hidden context to why maybe one group is not reaching the benchmark, and then that can help to further help us reach the benchmark that we've like set. And in those sort of narratives, maybe we're able to uncover barriers such as like transportation or like language access that isn't necessarily represented in just like an outcome performance stat. Further, incorporating patient voices helps to promote trust and transparency and engagement, right? One of the concerns that we've encountered is patients telling us that, what are you doing with the data? Like, how are you using it? And if we're able to, have that open line of communication with them of how we're using it, then one, it helps them to feel rest assured that we're treating this very carefully and that we are, treating it very ethically. And then helps to further continue that. If they feel safe and comfortable there, then they'll continue to share data. So that, like sort of a feedback loop. And then lastly, patient voice helps to enhance innovation and problem solving, right? And involving patients can lead to more creative and acceptable and sustainable quality improvement solutions. And so we're constantly trying to improve us, and Matthias mentioned how CQIs have been able to get the easy wins, right? And so sort of to get to the next level, this could be one of the different avenues that help to further progress there. And so there are many ways that, our different sites and hospital systems are currently involving patient voices in their processes. And as you look through this list, like think about which of these that your hospital may be using, or other ways that you can help to incorporate the patient voices into our quality improvement measures. And so with that, that's what we have for you today. Matthias and I are always welcome to any questions if you would like to further reach out to us. And I will turn it over to Keith or Andy.
Yeah,